missing donors, that the risk of the because with deceased donors we can have delayed function, and we know that delayed function per se leads to upregulation of class 2 genes within the tubular cells. For example, we have the non-sensitized patients, versus the sensitized ones. HLA matching, is it worth it, and the time to immunosuppression. So, a few words about kidney recipes from living donors. So, you know better than me all the literature about that. But just to recall, in fact, this is the CTS concrete transplant study from Heidelberg, Germany. I worked with Gerhard Roberts a long time ago. And so, this is a 4-year results, but showing that in fact, living kidney presentation is associated with a better allograft outcome as compared to cadaveric kidney transplants. But you see the difference is at the very beginning, but thereafter, the curves are very parallel. So it means that in fact, after the first year, there is no difference at all, but difference occurs within the first year. So, at the end of the day, it's better to have a living donors. So, how can we stratify? Yes, for sure, HLA identical donors are different from HLA haploidentical or more than 3 HLA mismatches. So I'm trying to look at HLA identical kidney transplantation and outcomes, but so far there are no randomized controlled trials, and so there are only small series of patients, so it's very difficult to address the long-term issues and long-term outcomes. The first question is induction therapy necessary? As you demonstrated, as you published some time ago, in the long term with regards to patient survival, graft survival, it's not necessary. The second question is, in the setting of HLA identical kidney transplantation, is CNI induction therapy necessary? Can we skip off CNI? We can discuss that with you at the end of the talk. Possibly we can skip CNI. However, if you look at the literature, the old literature, but the recent one also, there are reports of very severe rejections, especially in patients who have been transfused pre-transplant. And so therefore, these acute rejections are related to non-HLA gene. In my center, we transplanted a few years ago a male patient with an HLA identical kidney from the sister. They were HLA identical, but this was the 4th transplant, and he has had at day 5 post-transplant acute humoral rejection, very severe. And in fact, we demonstrated that he had antibodies against endothelial cells, and so we saved the kidney with plasmapheresis, rituximab, and some more energy. But just to say that in fact, CNI induction therapy, I think it's wise, at least for a few months. Thereafter, you can win off CNIs because they are actually identical. So we can have CNIs on board for 3 months, and thereafter we can withdraw step by step the CNI over a period of 1 month. And the second question is, what type of maintenance immunosuppression in these patients who are HLA identical? Should they be placed on azathioprine-based immunosuppression in the long run? In Western Europe, we've got a lot of skin cancers because the skin is light. And therefore, as you know, azathioprine accumulates within the keratinocytes for many years, and so increase the risk of basal cell carcinoma, spinal cell carcinoma, and so therefore we prefer to use microfilamic acid in the long run for those patients because there's a likelihood of having or developing skin cancers. But for me, in my center, the question is, what is the place of inhibitors in this setting of HLA transplant? So I just found on PubMed a few case reports, a case series of less than 10 patients where on several-space immunosuppression in the long run with very good results. And for me, in the setting of HLA identical kidney transplantation, there is certainly a place for inhibitors, and for me, they are more suited than NPAs with regards